Good morning, TB Program Oregon Health Authority. Can I help you?
Hello, this is Kamaile at Benton County Health Department. I just got a report from a doctor at the community clinic about a patient with tuberculosis. She's 28 years old. She's had signs and symptoms of TB disease. Her chest x-ray is abnormal but not cavitary. I advised the clinic on how to collect sputum. The results are back with AFB smear positive 2+ and a positive gene expert. The patient is originally from Vietnam and she sought care when she started coughing up blood, and she's had a month of weight loss and 3 months of coughing.
Where's the patient at now?
She's on home isolation. The doctor has already started treating her for her pulmonary TB.
Okay, great. It sounds like the patient's doctor has the treatment piece under control. But since she has pulmonary disease and a positive sputum smear, she might have infected her family, clinic staff, and others.
Right, that's why I'm calling. It's been a while since I handled a TB contact investigation, and I wanted to make sure I'm covering all the bases.
Contact investigations for tuberculosis can be challenging because the infectious period is often long and can be hard to define clearly. Other factors influence the urgency and scope of the investigation. TB disease is often, but not always, infectious, and some cases may be more infectious than others. For these and other reasons, each TB case investigation is unique, and each situation must be carefully evaluated before an investigation is started. When planning a contact investigation, consider these factors: the infectiousness of the case, the infectious period, the risk for transmission, and individual contact risk factors such as young age or immunocompromising medical conditions.
Okay, let's start with the case. We need to get an idea of how infectious she is and how long she's been infectious.
Well, her sputum smears are positive, and she's been coughing a lot for a long time. So she's probably infectious, right?
Yep, the TB is in her lungs and her chest x-ray is abnormal. We should assume she's infectious. The question now is how long she's been infectious. When did she start coughing?
She started coughing 3 months ago.
Got it. Okay, there are different ways to estimate the infectious period, which makes this a little complicated. CDC guidelines start the infectious period 3 months before the onset of symptoms, but sometimes it's more practical to consider the beginning of TB symptoms as the start of the infectious period. Either way, we're looking at a long infectious period, at least 3 months and up to 6 months. Because the period is so long, this could easily become a really big investigation. We want to avoid unnecessary testing, but also need to make sure everyone at high risk is tested. We're really going to have to focus on understanding the risk of transmission and identifying which contacts are at highest risk. Have you interviewed the case yet?
Not yet.
Okay, I think that's the next priority. I'd interview her as soon as you can and specifically ask questions about who she lives with, who visits often, and places like work, school, or church that she's been to since symptoms started. We have a form on our website you can use for this, and hopefully that'll help. As you might imagine, it can be hard for patients to remember everything. It might be helpful to ask the patient to describe her daily routine, what kind of transportation she uses, and what she likes to do in her spare time, etc. After you've interviewed the case, call me back and we can talk about how to assess the risk of transmission.
The infectious period is the time during which a patient can put others at risk by exposing them to the disease. The infectious period for TB cases is often long. The TB pathogen grows slowly, and symptoms can be mistaken for other respiratory conditions, resulting in delayed diagnosis. When planning a contact investigation, it's important to assess how infectious the patient is. If the patient has pulmonary or pleural TB, a contact investigation will be needed. Usually a contact investigation isn't needed if the TB disease is elsewhere in the body. If, after a review of clinical information, you determine that the person is infectious, confirm the date when symptoms started and use that to calculate the infectious period. The next step is to go through that period and identify when and where the patient might have exposed others. You can then go through that list with the patient to document names and contact information for people who were likely exposed.
Hi Heidi, it's Kamaile from Benton County Health Department. Just getting back to you about our young lady with tuberculosis. So I have identified 38 contacts. There are 4 adults that live with her, 3 adults and 2 children who visit the home regularly. 6 of the staff at the doctor's office saw her before they realized she might have TB, and then they went ahead and initiated appropriate precautions. She takes a community college class at night and drives to class in a car twice a week with 3 friends. She works part-time in a nail salon, and there are 8 other workers and 1 supervisor. But she's only worked there for a month. She went to the dentist recently, so there is the dentist, the hygienist, and 3 other office staff. She has a boyfriend, and she did mention several other friends she sees less often. This seems like a huge number of people to evaluate.
Yes, it does seem big. So we need to think about the places exposure occurred and set some exposure limits. Keep in mind that setting exposure limits is not an exact science. Let's talk some more about each group of contacts and try to figure out what kind of exposure they had and whether they have characteristics that put them at high risk.
When thinking about exposure limits, it's helpful to remember that even though TB is airborne, it's not as infectious as some other pathogens like measles or pertussis. It takes a lot of close contact with an infectious TB patient to become infected. Because of this, it's helpful to estimate both cumulative hours of exposure and the type of setting. Suggested exposure limits include 4 or more cumulative hours in a small, poorly ventilated space such as a car or enclosed room, 8 or more cumulative hours in a small, well-ventilated space such as an apartment, 12 or more cumulative hours in a large space such as a classroom or house, or 50 or more cumulative hours in a large, open area such as an auditorium. It's also important to consider contact-specific risk factors. For example, if the contact is a child less than 5 years old or is immunocompromised, they should be prioritized for testing.
Let me make sure I have this right. All her household members should be tested because they spent more than 12 hours with her at home. The regular visitors also likely had more than 12 hours of exposure, so they should also be tested. The 3 friends she rides with in the car should be tested because they were there with her several times in a close, poorly ventilated area. But we probably don't need to test her teacher or other classmates because her class is in a large auditorium. The nail salon is well ventilated. She hasn't worked there very long, so it's probably a good idea to test the salon workers, but we don't need to worry about the salon clients. Each client spent less than an hour with her, and we're several feet away from her, and because she's new, she doesn't have very many repeat customers yet. The dentist and hygienist might want testing because they were very close to her, but they were wearing surgical masks, so that might decrease their risk. The dental office staff didn't spend any face-to-face time with her, so they won't need testing. The doctor's office staff should also be offered testing, but they will get that through their own employee health program. The boyfriend probably should be tested, but her more casual friends may not need testing.
Right. We don't have a good idea of how much time she spent with her casual friends, so it makes sense to hold off testing them until we see how many close contacts test positive. How many people are on the list for testing then?
I think that makes 22. We can manage that.
Okay, are a lot of the family members, co-workers, and friends foreign-born?
Yes, many of them are originally from Vietnam.
Okay, that's important to know. Because they're from an area where TB infection is common, you should keep in mind that they may test positive even if they weren't infected by this case. Also, it's probably better to test them with QuantiFERON or T-Spot instead of a TB skin test. If anyone tests positive, they'll need a chest x-ray and treatment for latent TB infection. For contacts who test negative, you'll need to do a follow-up test 8 to 10 weeks after their last exposure to the case. TB infection can take several weeks to show up on tests, so a second test is essential to rule out infection.
Okay.
All right, a couple of other things. If there are kids under 5 or anyone highly immunocompromised, they'll need a PA and lateral chest x-ray plus preventative treatment during the 8 to 10 week window period, regardless of their test results. So, for those groups, even if the initial IGRA or TB skin test is negative, the contact needs a PA and lateral chest x-ray. If that's normal, start the contact on LTBI treatment with daily isoniazid or daily rifampin. When it's 8 to 10 weeks after the last exposure, give another eye drop or TB skin test. If the second test is negative, we'll need to decide whether to continue treatment or stop it. If it's positive, you'll just continue with treatment. Does that all make sense?
Yes, I understand. So kids less than 5 or anyone highly immunocompromised need the extra chest x-ray view and should start treatment for latent tuberculosis regardless of the test result. I'll give you a call at the end of the window period and we can decide whether or not to continue the treatment.
You got it. Also, if a lot of contacts test positive or a contact has TB disease, we might need to expand the investigation. Feel free to call me if that happens.
In this module, we've reviewed the key elements of a tuberculosis contact investigation. Public health activities will vary from case to case based on the level of infectiousness of the case patient and the duration and settings of exposure. Effective tuberculosis contact investigation depends on good communication between local and state public health staff, the healthcare provider, and the patient. These investigations tend to get complicated, but remember, you're not alone. Support from the state TB program is just a phone call away. This is what they do, and they're prepared to support you in this important work.